So good evening to all the aspirants present here. Good evening, sir. So the topic for today is GI, and we are going to have a CCS session today. And the speaker that we have here is Dr. Arun Raja Thangavel. He is a senior clinical fellow critical care at Guy and St. Thomas Hospital, UK. Thank you, sir. So you may continue.
Thanks, Padma. But I don't know what time is there. It's afternoon for me, yeah. I think
Sir,
roughly
it's
7 p.m.
7 o'clock here.
Yeah, and many people are from different countries as well. So welcome everyone. Uh, Greetings to everyone. So let me start by sharing my screen.
Sir, actually, you are not clearly audible to us.
Am I not? Let me change my speaker then. Is my screen visible?
Yes, sir.
Am I audible now?
Yes.
Okay, great. Yeah, again, welcome everyone. So my name is Arun. I've done my EDIC exam last year after having a training course with FARS Academy, and I'm just contributing back to the academy by being a faculty as well. So it's my pleasure. First of all, congratulations to everyone for being here. You have passed EDIC 1 exam and preparing for EDIC 2. If you've already got a slot for EDIC 2 exam as well, congratulations once again. You are in safe hands with us in FARS Academy, and it's one of the very few courses across the world which gives you an actual exam like scenarios and prepares you well for the exam. So, yeah. So objectives for the class. We will orient you for the EDIC Part 2 exam, especially for the CCS in this session. You will have a mock exam like scenario. This is how the actual exam looks like. So it simulates closely and it will be useful. And you can practice exam-based thinking and sharpen your answering skills. You will revisit some medicine, and I'll try and modify your answers to the European and UK expectations, as some of you may not have worked in European or UK countries. So let's try and keep it as much interactive as possible. So this is a good platform for you to try answering and practice your answering skills. So that's the only thing which is going to help you pass the exam easily, because you all know the theory behind it. It's how you prepare yourself for the exam and adapt to the exam scenarios, which is what is more important. So treat it like a mock exam and try and be proactive and answer as much as possible. If possible, keep your videos on, and as I can see, you've already named yourself on the platform, so which is good. And we will try to make it a round robin kind of questioning, and I would encourage everyone to come and answer here. And yeah, practice answering as much as possible with a structure and try and maximize your marks. Thanks, John. Feel free to interrupt anytime and clear your doubts. Yeah. I'm trying to see if we can change so that I can see all the participants. Give me a second. Okay, fine. So here we go. Any volunteers for the first question? Cannot see the entire list of participants. So if none of you are volunteering, I might. Why don't we have a quick round of introduction? I don't know many of you. If you type in the comment section what you're doing, or you can unmute yourself and introduce yourself one by one, so that it's easier for me to make it a discussion. Am I audible to everyone?
Yes, sir.
Oh, great. Yeah, yes, Pankaj, why don't you introduce yourself?
So myself, Dr. Pankaj from Raipur, Chhattisgarh, India, and I am doing my DRND.
Oh, great.
critical care from Raipur itself.
Mm.
I have done my MD anesthesiology.
All right. So Pankaj, would you like to answer this question?
Yeah, sure, sir.
Yeah. Just don't need to be formal and all. Even if you are making mistakes, it's absolutely fine. This is going to be a friendly discussion, how we can improve yourself and uh, move it forward. Yeah, go for it.
So I'm unable to see the question. Can I? mm, Can you please move the slides?
Uh, okay. Can you see my slide? A 52-year-old male with.
No, sir,
Are
not
you
able
not
to.
seeing my slide?
No, no,
Not
sir.
yet.
Okay. Let
It's the
me
aim
stop
and the
sharing.
ground rules that are still on display.
Okay. Let me share it again. Can you see my slide now?
Yes.
Yes.
Oh, great. Fine. Yes, Pankaj, go for it.
A 52-year-old male with non-alcohol related cirrhosis, childhood C, married NA26, present with hematemesis and pre-syncope. He is tachycardic, hypotensive. Examination reveals jaundice, ascites, splenomegaly. Resuscitation is initiated with IV crystalloid. Gastroenterology team is sent to a urgent referral and you asked to assess for critical care admission. How you proceed? So, since patient is hypotensive, uh, along with the IV crystalloid for his hematemesis, I would like to start with bolus dose of pantoprazole 80 milligram IV stat followed by 8 milligram per hour. Along with that, I would also start with. I would like to start with terlipressin or octreotide, whichsoever is available, and this is for hematemesis. And if patient maintains his yes, sir.
Okay.
I will start
Uh,
with ABC.
Okay, can I chip in something?
yes. Let me
Oh,
give one more chance to Pankaj. So the actual exam you've given the answer so far, they will if they wanted more answers or if they have like list of things to tick so that they can give you the marks. So if
I
they would
would
have ticked
okay,
few
sir.
points.
I would like to correct myself. I would start with ABC, and since patient has severe hematemesis, so to prevent the risk of aspiration, I would like to intubate the patient
Mhm.
for
Yeah.
intubate the patient, and once my airway is secured and breathing is secured with on mechanical ventilation, then I would like to go for C part, that is cardiac, where patient is hypotensive and patient has been resuscitated with IV crystalloid. So to maintain his map, I would like to add some vasopressor, and to prevent and for the treatment part of hematemesis, I would like to go with pantoprazole and terlipressin.
Okay. Perfect. John, you wanted to add something?
yes, I actually think that for this patient,
Can you introduce yourself first, John?
can you hear me?
Yes, yes, I can.
Okay, so like he said, it is important to start with ABC of resuscitation. Ensuring
Yeah.
the airway, because it's clearly stated that this patient has a pre-syncope. So the airway may not be patent. It's important to ensure this patient's airway is patent. And then a supplemental oxygen is given because he's likely to be anemic. So you need to increase the oxygen delivery to this patient, okay? And then since there's already infusion going on, you need to also send blood for grouping and cross-matching. You understand? And
Excellent.
then go ahead to give omeprazole infusion as well as telepressin to help to increase to reduce the bleeding from the splanchnic bed. Okay, and then arrange for okay, it's already been stated a gastroenterology team will be sent for concerning urgent endoscopy.
Okay, great. Anyone else have anything to add?
Meanwhile, we can stimulate the massive transfusion protocol and arrange for blood and blood products in case of massive bleeding. Also, we can take the call from intervention radiology people if they can help.
Is the speaker talking?
Yeah.
Okay, great. Fine. Yeah, take that point.
Preparatory zone
So-
is the zone, I think, before endoscopy. Antibiotic.
Antibiotic, excellent. Great, you're getting there. Yes, anything else?
We will take lab coagulation profile and follow chain
Yeah.
lab.
I think we kind of discussed everything. So this is how the examination is going to be. Like, unless you bring out all the points, they will be like, can you add some more or anything else? Anything else? They can prompt you like twice or thrice for each question. So try and make sure you answered in a structured way so you don't miss out on small things like which you assume generally like taking care of your airway, breathing, sending for cross match and arranging bloods, activating massive transfusion protocol if required. So try and answer in a comprehensive way but focused way, so not to waste the time, but also you get maximum points. So this is how I would have structured my answer. Once again, yeah. So giving importance to airway, see if there is any risk of airway compromise or aspiration risk and consider intubation. Oxygen, yes, of course, John. And get a whiteboard cannula, initiate, send off the initial bloods and blood transfusion. So here, assume if we have had like initial bloods, what's going to be your hemoglobin target? What do you think, Pankaj?
Sir, if it's active bleeding, then we will target a hemoglobin of 9 to 10. And if it's not very active bleeding or very profuse bleeding, then we can restrict ourselves to 7 milligram per deciliter only, because if we are targeting a high hemoglobin, then we may lead to increase the bleeding incidence in that.
Yes, and it comes with other complications. So many studies, even in the active hemorrhage phase, suggest aiming for a HB of 7 to 10 and avoid transfusion if the HB is more than 7. And it's again given by the guidelines to aim for HB of more than 7. And you mentioned something about vasopressors. And in this scenario, specifically with variceal bleed, if you are like overshooting with the blood pressure with a high dose of vasopressors, there is risk of more bleeding. So we should be mindful of that as well. And we did talk about massive transfusions, which is good. And none of you mentioned about coagulation. So if the patient is already on any antiplatelets or anticoagulants, of course, the history is not complete, but it's something to think about in any bleeding patient. So this could have had like a couple of points in the exam. So it's easy to miss out on this unless you think through it properly and have a structured plan. So yeah, think about reversing anticoagulation if the patient is already on it. And regarding antiplatelets, guidelines suggest to continue with aspirin irrespective of bleeding and discuss with cardiology regarding the stent risk of thrombosis and decide on the clopidogrel and other antiplatelets if the patient is on and stop further anticoagulants. And yeah, we did discuss a few. Coming to variceal bleed and specific medications, terlipressin, if it's available, yes, that is being advised by the guidelines, and other alternatives like octreotide and somatostatin can be considered. And erythromycin, it's not like a mandatory drug, but if the patient is going for endoscopy or more likely to have endoscopy, it helps with the views and it is suggested in the guidelines by American Society of Gastrointestinal Endoscopy Society. So that's something to consider. But I don't know if it's a mandatory thing or not, but it doesn't make any difference if we answer that. If there is no mark for that, fine. But if there is a mark for it, we will get one more point. And yes, we did speak about variceal bleed, antibiotics for variceal bleed, which is fair enough. And proton pump inhibitor, yeah, a couple of you suggested like starting with a high dose and continuing infusion, but the recent guidelines say otherwise. They are not for like routine prescription of proton pump inhibitors, and it depends basically on the endoscopic findings whether you start high dose proton pump inhibitors or not. It's not routinely advised. My take would be like to start with a stress ulcer prophylaxis, like low dose, and based on endoscopic findings, if there is high risk stigmata or further bleed, like an ulcer which is at high risk of bleeding again, then probably start the proton pump inhibitor infusion or high dose. Again, like 40 milligrams BD versus infusion, there is no strong evidence or recommendation from the society guidelines. Either it's European or American or UK based. So they all suggest like 40 milligrams BD seems to be a good dose. There's no emphasis on starting the infusion. That fair? Do you? Yeah, I had another slide. Can you see this? If I can move this, yeah. Can you see this bundle? So this is advised by the UK Society of Gastroenterology as a bundle whenever a patient comes with an hematemesis. So if you have time, just go through this bundle, which is good. If you, see this, first thing is recognition, alerting the team, and we do what we call a NEWS, National Early Warning Scale. So it's just the vital parameters, blood pressure, your heart rate and alertness, respiratory rate, saturation. Based on that, it gives a score, and the hospital system, if the patient is scoring high, meaning the blood pressure is low or patient is tachycardic, the system is automatically alerted. So the critical care teams and other outreach teams will get alerted automatically and they will come and see the patient. So this is not widely followed outside UK, but this is something good to know. And we discussed IV fluid resuscitation and transfusion targets and risk assessment. There is a question on the next slide. We will discuss more about that. And British Society suggests giving terlipressin 2 milligram QDS and start antibiotics as per local protocol and like bacterial resistance pattern, and to continue aspirin, suspend all other antithrombotics, and refer to the gastroenterologist if we think endoscopy is required. And it should be done as early as possible within 24 hours if the score risk stratification is high. And review the report, and based on that, if you see PPI, consider high risk of ulcer post endoscopy. So it's not routinely advised. Any doubts with this?
So do we need to say the doses of each drug, especially specific drugs during the answer, or let them ask the question?
It's not like required, but it's a good practice to even for us to remember the dose. And if you say it out, you saved some time. If that dosage adds some marks, we don't know how the answer key is set, right? So it's if you are sure about the doses, go for it. If you're not, leave it. Just go with the drug name. Happy?
Yeah, thank you.
So yeah, who wants to go next? Altaf, Stani.
So, sir, risk can be assessed with the help of Blatchford score, in
Mhm.
which we measure hemoglobin, urea, systolic blood pressure, pulse, and their melena and several other parameters. And it depends on the number of risk factors present 0, 1, 2, 3, 4. We can assess the mortality of the patient. So, we can stratify the patient according to Blatchford score.
Yeah, excellent. Any other scores from anyone?
We can also grade according to the hypovolemic shock present. blood loss less than 15% grade 1, 15 to 30% 2, 30 to 45%, and above 45% grade 4. So like that also, depending on whether only tachycardia is present or hypotension is present along with tachycardia. So we can grade like that also.
There is one more scoring system, sir, rock call scoring system.
Excellent. Yeah. That we will discuss about. Yeah. Yeah, it's difficult to remember all the scores, but Glasgow Blatchford score is a must-know score for hemorrhage, especially upper GI bleed, because decision making is made on this score, especially in UK, and it's been endorsed by the American Society and European Society as well. As you can see, Glasgow is from Scotland, and it was a Scottish physician who came up with this score. And apart from the parameters like urea, hemoglobin, vitals, they also give consideration for the comorbidities like liver disease, cardiac failure. And based on that, it's important in the sense they decide whether the patient needs to be admitted or not. If the Glasgow Blatchford score is like 0 or 1, patient can. Okay. So if the GB score is 0 or 1, we can safely discharge the patient. And if it's more than 1, they will be monitored in the hospital admission. It doesn't say who needs ICU admission or not, but what it says is if the score is more than 6, there is high risk of patient requiring intervention or critical care admission. So in that sense, it helps with the emergency physician department help with how to deal with this patient, and even us with referral to endoscopist, and for them like gastroenterologist to decide on whether the patient needs an urgent endoscopy or within the 24 hours in a reactive manner. So it's an important score. So this is the score. Yeah, if you can see here, there is more weightage for the blood urea nitrogen. So it just suggests like physiologically there is more hemorrhage which has been going on for a while, and the patient is having a lot of blood in the GI system. That's why the blood urea is high and it has a high score. And hemoglobin, to start off with, if the HB is 10, less than 10, the scoring is very high. And the systolic blood pressure again, if it's less than 90, the scoring is very high. And few points for the background disease, cardiac and hepatic disease. So based on this score, it's very important, and that's how the decision is made in like tertiary care centers. And other scores which are discussed in this setting are AIM 65, which gives out an inpatient mortality score, and rock call. This basically includes endoscopic findings into the scoring system, so it's more useful for gastroenterologists rather than us. So in the acute setting, most useful score to know is Glasgow Blatchford score, which may be asked in the exam. So all the topics which I'm discussing today are like very important. At least one of them will be definitely coming for your exam. So be attentive. And who is ready to take the next question?
Okay, let me try.
Who is this?
Tranexamic acid. Tranexamic acid has, yeah. So what's the role of tranexamic acid? Can you hear me?
Yes, yes.
Okay. Tranexamic acid has no role in GI hemorrhage, but usually it's in trauma, trauma and in obstetric hemorrhage that is commonly deployed.
Yeah. Do you have any evidence base? Can you it's always good to quote a study if possible. It's not necessary, but if you have any study associated, that will give you maybe extra points. I don't know.
ALTED trial.
ALTED, excellent. Yeah. You can read about it. Yeah. So ALTED trial, since that people have moved away from using tranexamic acid. Also in the secondary outcomes, it did show increased incidence of venous thromboembolism. Not had the same outcomes in other studies, but this one study was of particular importance. And none of the guidelines discuss about tranexamic acid anymore. So it's a clear no for tranexamic acid in GAMH. Good. Let's go to the next step. I would encourage other people to participate as well. Whoever is available and able to unmute themselves, please go for it. Unless you come up with the answer, even if you know the answer, just putting it out in the exam is more important. Within the short time frame, you are like time limited. So practice answering. That's what going to help you. You may read and revise 1,000 times, but unless you open your mouth and practice answering, it's not going to help. Asha, Ravi, Bilal, anyone? Otherwise, we'll have to go back to John.
Okay. Portal hypertension is elevation of the pressure in the portal veins, and I think the cutoff is a pressure of 25 millimeters of mercury. Then how can it be managed? It can be, the initial treatment will include the use of, I think, is it salbutamol or so? Oh, sorry.
Beta blocker.
Beta blockers. Yeah. And then when it becomes refractory, then the trip shunts can be undertaken.
Yeah, I think John was quite right. Yeah, we all know it's elevated pressure in the portal venous system. So how do we measure it in an objective way? We cannot actually measure the direct portal pressure unless we do like endoscopic ultrasound and put a probe across the portal vein directly and measure it. We cannot actually measure it using Doppler. So we can indirectly measure it using catheter studies, putting a catheter in the hepatic vein. If you see the image here. So this is how actually it's measured. You put a catheter across the hepatic vein and wedge it and get a value and deflate the balloon and get a reading. So the difference is what is indirectly the measurement of portal vein, similar to PA pressure with wedging to measure the left atrial pressure. So kind of similar method to get the hepatic venous portal gradient, and 5 to 10, less than 5 is normal, 5 to 10 is mildly elevated, and more than 10 is clinically significant. And risk of variceal bleed is more than 12. Again, we don't routinely measure it clinically, but at least to understand the pathophysiology, it is useful. And the management is basically how we manage the ascites, refractory ascites, diuretics, salt restriction, and beta blockers if we think the portal pressure is elevated, and endoscopic ligation or banding procedure, and as John said, tips. Yeah, so these are simple questions, but we don't practice answering these normally. So if we just say like beta blockers and leave it, you might miss out on 4 other marks. That's what I try to just tell you, emphasize on you with this slide and question. Okay, moving on. So we have been discussing only the first case scenario, and now the patient has progressed. So there will be multiple vignettes of how the patient progresses or worsens over the admission, and then we will discuss a couple of questions. This is how the actual exam in a long case is going to be like. Yeah. Yes. Any new participants brave enough to unmute and answer? Otherwise, Asen, Mahesh, Salah. Any of you would like to go for it?
Patient have hepatic encephalopathy, and he
Who
has
is this?
acute kidney injury, maybe hepatorenal syndrome.
Your voice is not very audible.
That's why I'm telling patient have hepatic encephalopathy and acute kidney
Yes.
injury, maybe hepatorenal syndrome.
Yeah. So the question is, how do you grade and manage the hepatic encephalopathy? The questions are going to be simple.
Grade
It's
2
how
hepatic
well we
encephalopathy.
answer the questions. Yeah. Go for it. Sorry.
If patient is still conscious but confused and he has inappropriate behavior, it goes to grade 2 to 3 hepatic encephalopathy. Grade 2 mostly.
Grade 2. Perfect. Yeah.
And for management of hepatic encephalopathy is protein restriction and colonic lavage with repeated enemas, with decontamination, colonic decontamination with flagyl, metronidazole, with antibiotic and electrolyte correction.
Yes. Anything else?
Just ammonia can be removed also with CRRT. If we can start CRRT for renal impairment, it will help in management.
Yeah.
Of hepatic encephalopathy.
Anyone else have anything else to add? Dr. Anika?
Considering hepatorenal syndrome, we have to start albumin as well as terlipressin for the treatment of hepatorenal syndrome.
Yeah, we haven't quite gone into hepatorenal yet. We are just discussing with hepatic encephalopathy. I have another
So
questions
since-
coming for that.
So since the ammonia is high, we also need to prevent brain edema by giving lactulose or mannitol-like substances. At this point, we also need to give antibiotic and also to prevent the precipitating factor like bleeding, GI bleeding.
Yeah. Right. Great. So, yeah, I agree with Dr. Mohammed. I feel it is grade 2. Patient is confused, disorientated. I mean, the difference is quite not very clear with many, like if you see the West Haven criteria, but if there is some suggestion towards like gross confusion, I would say grade 3. If it's mild confusion, I would restrict to grade 2. They might ask you the grade with a clinical picture. I was asked similar questions, so this might very well be asked. And disorientation, again, disorientation to time, it's grade 2. If it's like person and place, it's grade 3. If you look at different West Haven criteria across multiple papers, they give some more details about how to specifically grade the people. So yeah, that's something to think about. And we discussed the laxatives, lactulose. Initially, maybe we can start with a higher dose and maybe cut down to 30 mils, literally aiming for like 3 to 4 bowel motions in the beginning. And antibiotic, specifically, I think we should mention rifaximin because this has been discussed in the guidelines and suggested. Rifaximin, the dose I've given 550 milligrams BD, and yeah, I think instead of blanketly saying like antibiotics, of course, we will be treating for spontaneous bacterial peritonitis, thinking that in mind. But specifically for hepatic encephalopathy, we should add in rifaximin. Lactulose and rifaximin are the two pharmacological agents which is uniformly recommended across many guidelines. So that I think we should say it out. And correct electrolytes, maintain adequate nutrition, supplement micronutrient deficiencies or vitamin deficiencies, and thinking about time in year is crucial as well. And treat for spontaneous bacterial peritonitis, avoid sedatives, which can precipitate hepatic encephalopathy. So again, none of us mentioned avoiding sedatives, if I'm right. So even that may carry a point. So it's these small things which we often ignore or like overthink. So that's where we lose out on marks. And these are like simple marks to uh, get right. So EASL, the European Society of Study of Liver, I would recommend you to go through this guideline for hepatic encephalopathy. So they have like in 2022, they have published the guidelines and it's most recent. And the other things like L-ornithine, L-arginine, and sodium benzoate, these are often studied in refractory cases, but it's not part of the guidelines. So I don't think we need to discuss those things. Yeah. Other important thing is we all assumed it's hepatic encephalopathy, but are we sure what could be the other differentials?
It could
Dr.
be
Anika?
uric NCAF also, because
Sorry?
creatinine has also increased.
Mm-hmm. So I didn't get what was your diagnosis? Differential?
It could be HRS also.
Yeah, valid, yeah.
Uremic encephalopathy also can be or acute stroke or meningitis
Intracranial bleed
encephalitis.
as well. Delirium or
Yes.
alcohol, acute intoxication of alcohol as well.
Exactly. We should consider all these things, right? Yeah, that's correct. Let me see. Can go back. Presentation. Yes. Alcohol withdrawal, the patient, we don't know how much he was drinking. So that's one thing to consider. And that's the reason we give them time in practically. And Wernicke's, yeah, CNS infection, CNS bleeds. And the guidelines do talk about like considering CNS imaging like CT or MRI brain if we are suspecting like alternate diagnosis. I would like to stress upon the value of ammonia in chronic liver disease. It's more useful in acute setting like acute liver failure. The rate of ammonia rise or how high the value is has more value. But in a chronic setting, ammonia doesn't have much clinical value and it can be random, it can be high, it can be low. That even the trend doesn't add much to the clinical diagnosis. So I'm not sure how much it's going to be useful just chasing the ammonia values in chronic settings. But yeah, in acute failure, I agree with the renal replacement therapy and bringing down the ammonia levels, but not very much in the chronic setting. So let's move on. Any doubts so far? Okay. Who is ready to answer this question? Somebody already started speaking about hepatorenal syndrome. Would you like to answer this?
So hepatorenal syndrome is has some criteria to get diagnosed. Firstly, patient should have increase in serum creatinine by 0.30 milligram per deciliter in 24 hours. Patient doesn't have any intrinsic renal parenchymal disease. After withdrawal of diuretic and albumin, there should not be any improvement. There should not be any septic shock and any shock stays. And patient should have ascites and chronic hepatic.
Yeah, pretty much you have covered it. And the treatment? I think you already
Drug
discussed
of
it as well.
choice is albumin. Along with that, we have to use terlipressin or octreotide.
Terlipressin and albumin. Very good. Yeah. So straightforward question, and we all know what's the answer. So just making sure you cover the entire thing, so don't lose out on marks. So we should have cirrhosis and the AKI, and no improvement with volume expansion. You have given albumin already, but still patient has not responded, and we have held off on the diuretics. There's no shock. You have corrected that. Basically prerenal and post-renal causes for and making sure there is no correctable causes for this hepatorenal, AKI. And I agree, terlipressin and albumin. Pankaj, can you explain about the pathophysiology of hepatorenal syndrome? Why the AKI is happening in chronic liver disease? I'm sorry.
Sir, in with chronic hepatic disease, we have the deficiency of nitric oxide. There is a splanchnic vasodilatation, which leads to renal vasoconstriction, and it compromises the perfusion of the kidney, and that leads to hepatorenal syndrome.
Excellent. So there is splanchnic vasodilation, endothelial activation, inflammation, glomerular hypoperfusion that's causing the kidney injury rather than other correctable causes. So I agree with you, Pankaj, with that. Okay, moving on. So the any other volunteers? I'm running out of volunteers.
Me, sir, I'll try this.
Sure, go for it. Go for it.
So the patient requires intubation for worsening hepatic NKF and desaturation, worsening oxygenation, airway pressures are increasing, and uric, and IAP is 25. So
That's intra-abdominal pressure.
what defines abdominal compartment syndrome? So intra-abdominal pressure above 20 millimeters of mercury in the presence of organ dysfunction is called abdominal compartment syndrome because it compromises the abdominal perfusion pressure. So which grade of intra-abdominal hypertension this is? So 12 to 14 is grade 1, 14 to 16 above 20. This is grade 3.
Take a guess. We will keep it grade 3 for now. Yeah. How do you manage?
So management will be first relax the patient. So I will manage ABC. First, I will ensure adequate oxygenation. I will relax and paralyze this patient, provide adequate sedation, and then I will do a urgent surgical call for they want to get this investigated. I will get a CT, contrast enhanced CT of the abdomen done to look for the cause of abdominal compartment syndrome. Simultaneously send an intervention radiology call for this and a surgical call also. If they want to explore and maybe.
Abdominal decompression also, we can try abdominal decompression with NGT insertion and enema and paracentesis.
Yes. I will also put an NG tube to decompress the abdomen and also enema to stimulate the GI motility. Prokinetic agents can also be added.
Paracentesis also for any fluid like ascites or something.
Yeah, that's more relevant, isn't it? This patient probably has ascites and it's worsening. Yes, I agree. We need to look for other options, and
More important is that we have to be very precautious about the fluid resuscitation, because in ICU many a times fluid resuscitation is one of the factor of abdominal compartment syndrome.
Yes, very good, Pankaj. We should be mindful of avoiding excessive free fluids as well. Yeah, totally agree with you. I think we discussed most part of it. Thank you, Pika. That was well answered. So, yeah, sustained intra-abdominal pressure more than 20 with new organ dysfunction. So that's the definition of abdominal compartment syndrome, and it is grade 3. And up to 20 to up to 20, it's grade 2. From 15 to 20, it's grade 2. And 20 to 21 to 25 is grade 3. And more than 25 is grade 4. So who gives this definition and advice? So that's the World Society of Abdominal Compartment Syndrome. There is a society for everything, and they are good at giving us the definitions and guidelines. So these recommendations come from the World Society of Abdominal Compartment Syndrome. And I would recommend go read their guidelines in the website, and it's well written. And that's the best place to find the answers if you are anything about abdominal compartment syndrome. And yes, for this patient in particular, he needed an emergency large volume paracentesis. That's not going to bring down his intra-abdominal pressure the maximum. Of course, NG decompression, bowel and bladder decompression, and restricting crystalloids. What else do they have? Yeah, adequate sedation and considering paralysis. Yes, I agree. One more bonus question for Pika. How do you measure intra-abdominal pressure?
With the help of Foley's catheter, we insert 20 mils of normal saline into the Foley's, into the urinary bladder, and then we allow that to equilibrate with the help of a manometer. And the zeroing is done at the level of the pubic symphysis. And then we measure the intra-abdominal pressure. It comes in centimeters of water. We then multiply this by 0.86 to give the millimeters of mercury reading for abdominal compartment.
Excellent. Excellent. Also, we should be careful of the patient position. For measuring intra-abdominal pressure, patient should be flat and adequately sedated, meaning there is no ventilator dysynchrony, either well sedated or even paralyzed, and measured at end expiration so that it's not affected by the airway pressure. Make sense? Yeah. So I think it's an important topic, abdominal compartment syndrome, and EDIC people love this question, so it might be one of the questions. Keep a note of it. Right. Yeah, who wants to go next? Somebody new? Tom, Pony, Ratnakumar, Ravi. Do you want to have a go? Not, we will go back to the old people. That's all right. It's open to the
So this is
entire
showing
audience.
pleural effusion, sir, large pleural effusion.
Yeah, you mentioned transferring for CT. Unfortunately, patient is so sick, we cannot transfer him. As a focus done. And can you spot which side it is?
Left spleen is.
Yeah, I didn't have an image with the liver on, so that's why I had to put with the spleen on. But what's your comment on the pleural effusion?
It is septated effusion, most likely infectious cause because it is exudative.
Yes. So more likely, the right word is complex looking effusion. So the patient is septic and requiring more and more vasopressors, already growing E. coli, and the lung ultrasound is having this in picture. Imagine this is on the right side. It's not the spleen. Imagine that's the liver. So now patient is like 5-6 days in the ICU and developing new sepsis. What do you think are the likely sources?
Perhaps there is translocation of bacteria from the ascites to the pleural cavity, leading to infection. And
previous paracentesis was like not suggestive of infection, which is strange. But yeah, and you've done a large volume paracentesis and covered with antibiotics anyway, still the patient is worsening. So what's happening?
Pneumonia, hospital acquired or ventilator associated pneumonia.
Yeah, could be. Yeah, we don't know. We haven't ruled it out.
But this is pleural effusion, no, sir, shown.
Yes, yes. Yes, there is definitely pleural effusion. And I'm just looking for that word, the diagnosis. Yes, it could be infected effusion, but what do we call it?
Exudant.
Empyema.
Exactly. And wants to answer the next question as well. So the random cortisol, I know we don't do it regularly, but in a septic patient who is like requiring loads of vasopressors, how do we manage? What do we do differently in the management?
We
And
give
this
We'll
is
give
relevant.
stress dose hydrocortisone.
Exactly.
Stress.
Yeah, that's what I wanted. I wanted to add these questions in this scenario specifically because chronic liver disease patients are at risk of adrenal insufficiency because of multiple pathological reasons. And anyway, in septic shock, we would add in like stress dose of steroid. So that's why I put it. And the spontaneous bacterial peritonitis, we are all aware of, but there is an entity called as spontaneous bacterial empyema as well. So that's why I put it specifically. And these EDIC examination, the clinical case scenarios are picked up from life, like case reports or real life cases which the examiners would have faced. So it could be like anything. We cannot go by the book like progression from AKI to renal replacement therapy. It may not follow the same order. It may be something random like brain abscess, which we have missed or something. So have an imaginative mind. It could be any case in the real life scenario. So that's why we should go with an open mind in this EDIC exam specifically. Yeah. And yeah, it could still be like catheter-related bloodstream infection, who knows? So, futility. So this is something which is not widely discussed outside of Europe or UK. May not be like regularly discussed in African or Indian subcontinent. So, what is futility, and when do we consider like whatever the efforts we are taking or not going to be helpful and the patient is dying anyway? So when do we consider that in an objective way in this setup, particularly for this case? This is open to everyone.
In
We
case
know the
of some
patient is
advanced
yeah.
liver disease, in case of
Mhm.
advanced liver disease where we don't expect any improvement, or when transplant could also not be done because of the severity of the disease, we can consider futility of treatment. Also, when there is no response to the medical management which we are doing.
Yeah. So the patient has multiple failing organs, and so getting the overall picture of this patient, the patient with the chronic liver disease, probably cirrhotic liver disease, alcohol related, has come with upper GI bleed and has
Sorry to
developed
interrupt
multiple
you, sir.
complications. Sorry?
Sorry to interrupt you, sir. What we do, what we, how to define the futility means. What do we mean by futility?
So
Sound
futility
is
is
very
term which basically,
you can make sound
yeah,
more, please.
sorry,
Now it's better,
Mohammed,
yes.
were you saying something?
Sound on the higher sound. Voice is less.
Oh,
Speak more,
my
yes.
voice. Sorry
Yes.
for that. Am I audible now?
Yes, better now.
Okay. So futility is when we consider the measures we are taking are not useful and just continuing with the like aggressive treatment measures may not be in the best interest of the patient. So that's when we consider like futility. And this question I specifically added because in end stage liver disease in this setting, it has like specific objectives given by the European Society. So that's why I added this question. And what I was coming to is what is the diagnosis here? So this is a chronic liver disease patient who has come with GI bleed and developed multiple organ failures one by one. So how do we put it? What's the new terminology which is being used for such cases?
In this stage liver disease.
What was that?
In this stage liver disease.
Oh, that's used to be the old terminology, but now in research and liver transplant communities, there's a new terminology, like new diagnosis which is being used regularly and will be routinely asked in the exam.
Acute on chronic liver failure.
Exactly, excellent answer. So why it's important to label it differently, like acute on chronic liver failure?
Because there has been a sudden decompensation of liver function after a stable course in cirrhosis. So this is acute on
Yeah.
chronic.
Yeah, so we will discuss this more. So the answer I wanted you to know is, so the European Association of Study of Liver suggested like criteria when to consider withdrawal of intensive care support or move towards redirection of care, what we call as moving from active resuscitation to like comfort care measures and stuff. So this is when we start thinking about it. Patient has deteriorated despite best efforts in like for 7 days, having multi-organ failures, especially more than 4. And this scoring is important, CLIF C ACLF in this diagnosis. So if the scoring is more than 64, so basically the CLIF C ACLF score is the table which is marked based on this and literally gives you the probability of death at like 1 month, 3 months, 6 months, and 1 year. So for this patient, I calculated the score and it's coming to like 69, and the probability of death with like without any liver transplant is almost reaching 80 to 90%. So this is really helpful in like defining the prognosis and leading the discussions with the family. And why the terminology of ACLF has gained significance is because previously the liver transplant candidates were stable chronic liver stage disease, end stage liver disease patients. These patients where they had an acute deterioration were never considered for liver transplant. But now with these new scores and more research, this is a subset of patients who are having very high mortality. And unless they have liver transplant, they are definitely going to die. But outcomes, if they have had a liver transplant, has been equivalent to the others, like stable chronic liver stage, end stage liver diseases, irrespective of whether they have been drinking or not. So that's why it's very important to come up with this score and make these patients be considerable for liver transplant, especially in societies like UK, where the number of liver supply is very limited. So they need to prioritize who gets the liver in a democratic way, rather than like in different countries where private patients get preferred. So there's a lot of politics behind that, but in like a democratic way, how the liver is going to be allocated is based on these research findings and mortality predictions. So this patient was denied liver transplant because he has been drinking even before the admission. So the policy for like how long the patient has to be abstinent from alcohol before they can be considered for liver transplant varies across countries. For example, in Europe, it's like 6 months in some countries. In UK, it's up to 1 year, and it's not at all criteria in some places. So it depends from country to country, but we should be aware of what's going on, right? Yeah, any questions with this?
Sir, one question.
Yeah.
Sir, for the acute on chronic liver failure, what you have just mentioned, so other than the alcohol, what are the other causes for this causing this acute on chronic liver failure, like GI bleed, dyselectrolytemia?
Yeah, you are coming up with the answers yourself. Why don't you say the other causes as well? What are the, basically your question is what's the cause of decompensation in
Exactly. Yes, sir.
ACLF, right? So what do you think of the other causes? You have already mentioned a few.
Sir, high protein diet, constipation.
Yeah, these are like hepatic encephalopathy precipitated, but can be accounted for ACLF as well. But as you said, like GI bleed, infection,
Sedatives.
malnutrition. Yes.
Diuretics or sedatives can also precipitate.
Yeah, and of course, continuing alcohol and could be infection or a cancer. We don't know. Like it might be developing hepatocellular carcinoma or having a new hepatitis infection which has put him off, or some random infection which is stressing him. So there are different causes
Some
of
stress like
decompensation, but
operative
they have a
also
good
abroad due to
prognosis if
some
they have liver transplant on the same like early rather than late. So that's the whole purpose of bringing up with this CLIP CACLF score and having a lot of research going on in this field. Right.
stress, also operative stress, and some drugs cause decompensation.
I missed your comment.
Stress, and operative stress like surgery and some drugs
Yeah,
cause decompensation also.
exactly. Yeah, I agree. So,
Sir, sir, excuse me,
yep.
sir. Sir, I have a
Mhm.
doubt. Is
Yeah,
decompensated liver disease same as this acute on chronic liver disease? What's the difference between decompensated and this one?
it's pretty much the same thing, but this term like ACLF has new significance because of it's associated with the liver transplant. So the new research, especially the author who have published this CLIF ACLF is Dr. Jalan, who is working in UK currently, and he is the one who is leading the research on like the ACLF topic and how we can make them candidates for liver transplant, which they were not previously. So that's the importance more than just they have just relabeled the decompensated liver disease as acute on chronic, just to add more value and more significance to the new term. Like we just don't treat him. The definition difference between decompensated liver disease and end stage liver disease is not huge. But by
Okay.
bringing a new terminology like ACLF, they have made it a separate entity, like three ends of spectrum: acute liver failure, acute on chronic, and end stage. So
Okay, sir.
they have brought a uniform label to this disease and highlighting the significance. I think that's the reason.
Okay, sir, one more doubt. So one doctor
Yeah.
had already explained, but I missed it. How can we measure the intra-abdominal pressure using the Foley's catheter? Can you explain
Yeah.
once?
Yeah, so there are like specific kits available to do this, like intra-abdominal special Foley's catheter, which is available specifically for this purpose, if you have to do it in the right way. But like we have our own jugards, like normal Foley's and attaching a manometer to it, and basically reading it like arterial pressure monitoring.
Okay.
But apart from the setup, like equipment itself, you need to make sure the patient is lying flat and the actual intra-abdominal pressure is measured by negating the effects of the lungs, airway pressures, or the tummy should be really relaxed. So either we sedate them nicely or paralyze them and measure it.
Okay, sir.
Okay.
Thank you, sir.
So last slide of this case scenario. So don't be surprised if you get asked on like ethical questions. Like for those working outside UK or Europe, this may not be an easy way to answer this question. So it's better to practice and get your mind into like how to answer these questions. So just be prepared for it. Anyone want to take this and have a go? Tika, would you like to have a go?
Sir, because here daughter is wanting everything to be done and son wants to take to comfort care. So in such a situation, patient's prognosis should be discussed very clearly with the family members, and it should be made clear that what kind of prognosis is there, whether transplant is available or not, what is the scope of improvement. Like in this patient, there's hardly any scope of improvement, but if still there exists an ambiguity between the two family members, it is better not to withdraw the care, because there should be consensus amongst the family whether to continue the care or to just provide a comforting kind of a care. So that consensus needs to be made with adequate, and this should be a multidisciplinary decision. We should involve like gastroenterologist, critical care physician, and um, hematologist maybe, so that to help the family to make to a common decision.
Exactly. Yeah. So certain key words you need to note it down, like to answer in the exam. So make sure, even though like everybody understands the patient is going to die anyway without liver transplant, everybody from the family should be on the same page to move forward with the DNA CPR or withdrawal of life support treatment. So the UK law, as far as I know, is like it's a medical decision, making a patient like DNA CPR, but still the family needs to be on board. If there is disagreement, then what do we do? That's when we go for like a second opinion from our own department or a different department, like you mentioned, multidisciplinary team meetings. So patients acceptance is better if there is like different consultants or multiple teams talking to the family rather than just a critical care team. And despite that, if you are not like reaching a consensus with the family, then what are the other possibilities? So you can use hospital ethics team to get involved, or family liaison team sometimes, or use a third party mediation service, which is entirely independent from the hospital. Or in the last case scenario or the worst case, we can ask for legal advice. We can file for a court order and wait for the court to tell us what to do. This specifically comes where the patient is not dying, but like not dying actively. We are discussing like active extubation or stopping vasopressors, and the family is not in agreement, and that's when we go to the legal advice and wait for the court orders. Yeah.
Also, sir, we can say that there should be a committee should be made regarding in the hospital with senior members, senior faculty members to take a, because it's a difficult decision. So maybe few seniors are required to make to a consensus regarding this.
Yeah, ethics team does
Yeah,
include
ethics.
like senior members of the team, and yeah, that's how you escalate if there is any disagreement. Fortunately, we don't have like we rarely develop like having to reach the court to reach a decision, but most of the times with second opinions or MDT discussions, it is resolved, right? And this is where the objective measures like CLIF ACLF score helps us. Even previously milled scores gives us mortality risk based on how unwell the patient is. So we can exactly quote this and this percentage of risk of mortality at this time point. So it helps the patient family to come and understand how unwell the patient, rather than just saying patient is sick and is going to die. So the more and more we are doing critical care, the patient relatives are going to be well educated, and they will be asking for more like objective measures, and that's where these scores come in handy and help us out. So, so we have decided to palliate this patient. So what are the options? The patient has improved after like chest drain insertion for the empyema antibiotics, but still is not a candidate for liver transplant. He is slowly dying, but not dying actively. So how do we palliate? What are the options for palliative treatment in this patient?
Yep.
So these are the things which, yeah, go for it.
Sir,
Yes,
during
please.
palliation, we have to take care of patients' hygiene, personal, mental, social, physical well-being. We have to take care of patients' in nutrition, family involvement. That's what we have to do. We don't have to aggressively treat the patient rather than going just for the maintenance of the disease and the patient.
Okay, would you do like paracentesis therapeutic paracentesis just to make the patient comfortable?
If 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 patient is uncomfortable, then in that scenario we can opt for paracentesis rather, but we won't opt it for some therapeutic or diagnostic purpose.
Yeah.
We
I
should
agree.
manage pain if any present and provide
Yeah.
adequate sedation and analgesia.
Yeah. So big university teaching hospitals have like palliative care team. So they come and take over kind of the palliation stuff if they are stable enough to go out of the ICU. So they follow the patients in community as well. So what we can offer is like regular paracentesis for ascites if it's like causing discomfort, or continue with the lactulose and rifaximin, continue with the nutrition, maybe try and avoid like intubation, ICU admission, and stuff like that. And so these are the patients who come in with a high mortality risk who need an early referral to palliative care team. So they come and talk to the family, and it helps the family get prepared as well and make the process of death like quite peaceful for the family as well as the patient. So yeah, this is something which is upcoming in the field of critical care. Not all the hospitals have this palliative care team, but we can expect questions from the exam point of view and be prepared for it. Any questions? I think we have covered quite a few important topics and touched upon many important exam questions. If you have any questions, please feel free to ask. Otherwise, we have exceeded our time.
Thank you, sir.
Thank you so much. Yeah, do share any feedback if you have anything need to be improved on. Meet you in the next class then. Do read up and come. It will be a CBS session next on GI with me. So yeah, it will be interesting.
Thank you, sir.
Thank you.
Thank you, sir.
Fatma, I think we can close the session. Thank you.